today's episode, we're going to talk about HRT and vaginal dryness in menopause. I'm Dr. Davidson from Progress Your Health.
And I'm Dr. Mackey from Progress Your Health.
So if you're new here, we talk all about HRT, menopause, perimenopause, pretty much anything that has to do with hormone imbalance. And we've gotten so many questions lately. I would say we have a whole thick list of questions from listeners of the podcast. So we're going to go over a question from a podcast listener.
Yeah, this question is from Cindy. Now, granted, these are
change everybody's names.
Change everybody's names, but there's a theme to the questions. But there's always a little bit of a different way to approach each one. That's why these questions are so interesting, both for you and I. They're sort of fun to play around with because women are all doing relatively sort of the same type of replacement, just kind of diving into the detail and kind of tweaking it as we would with our own patients. So why don't you go ahead and read Cindy's question.
So let me grab my glasses here. So this is a question from Cindy. Now she's taking some hormones and she's wanting some guidance on what she's doing and also with some of the symptoms she's having. So, hi, I am 52 currently and on testosterone Cypionate, 200 milligrams per 1 ml, injecting 0.06 once a week. I'm on progesterone, 200 milligrams orally, and Biest, a 50-50 ratio of 1 milligram per day. I came off of pellets to this regime now. I was doing fine until the past 3 months, all of a sudden, got back my vaginal dryness pretty bad. My testosterone had gotten pretty high at 334 from my normal 219 because the compounding pharmacy gave me Depo-Testosterone instead of my normal Cypionate. I know the Depo is just a brand name, but it really threw everything off. I've since stopped the Depo, went back on my Cypionate now for the past month. With that said, I'm still having vaginal dryness. Do you think it could be due to the testosterone being dominant, or do you think I need to up my Biest cream? I do use and have used estriol vaginal cream for years, and it's not helping. I tried one night doing 1.5 pumps of my Biest cream, and the next day I did have more discharge. Any help is greatly appreciated.
Yeah, so she goes through quite a few different things here. She goes from pellets back to not only a combination of Biest, but also using a injectable testosterone. Anytime you're using Cypionate or the Depo she mentions, that's always going to be an injectable. What are your thoughts in general about using injectable testosterone?
You know, to kind of clear away and just talk about that point first, we are going to get into the vaginal dryness. I do feel like the injections for women can cause so many side effects. Now, granted, she's only doing, if you do the math here, about 12 milligrams of testosterone, but it's only one time per week. What I find with women is really, I hedge away from the injections because you can get this huge bolus of testosterone in your system, hence that's why it's up there at 334. Of course, we don't know when she tested, so as soon as she does the injection, that testosterone level is going to go really high, but then it's going to come down until she does her next injection. So it's really kind of having these kind of mountains and valleys of testosterone that I don't feel like it's really stable enough. I tend to like to do testosterone at more of a transdermal as a cream and then doing it either daily or maybe as minimal as 5 days or 3 days a week. But really, I feel like keeping the level more even, you have better symptom relief, and then you don't have some of the negative side effects of having too much testosterone.
Yeah, I see the once-a-week injection with men. That's a very common. You go to a hormone replacement clinic for men, and they're either doing it once a week or twice a month. I don't necessarily agree with that either. Certainly for men. For women, it just seems like they're just repeating the same process there. And I would agree with you. I mean, granted, you and I almost routinely use transdermal creams. Now, what are your thoughts? She came off pellets and now she's got a new regimen. What are your thoughts of using pellets?
The same thing. You insert the pellet, the levels go really high, and then you got to wait it out till they come back down before you replace that pellet. Some women, if they have a lot of symptoms from having too much hormone from that pellet, there's really nothing you can do except sort of wait it out. So I do feel like that kind of like is, again, having that bunch of the hormones and then it comes down and then you get another pellet injection or another pellet placed, into your upper rump there. It's still, it might seem easy in theory because you don't have to do anything other than getting, a little pellet, surgically put in your rump there. But at the same time, I don't I don't think it really has a finesse of hormone replacement, because hormone replacement therapy is really, there's science behind it, but then it's also an art to find the right treatment protocol that's going to fit for each particular person. Everybody's on a different hormone regimen. You know, I'm on my hormone regimen, which I can get into later about what I'm doing, you know, at 51. And then, you know, here for Cindy, she's on her own personal regime. So we want to find that uniqueness there, where I feel like doing the pellets or doing the injections, you don't really get that finesse.
So she doesn't say anything here, but I'm assuming that she says I came off pellets. So we could assume there that her pellet regimen was just testosterone only.
They can put estrogen
or do you think hers was a combination?
It might have been a combination between the estrogen and the testosterone, but the way she words it, well, yeah, it could have been a combination of the estrogen and the testosterone. Then they usually do that as a pellet, and then they take the progesterone orally separately, especially if they have a uterus. What I find with a lot of women is after a while they kind of get, they don't really want to have it put in anymore. It's kind of a process to have a little scalpel slice in your upper rump and injecting that pellet in there. I know that gets a little annoying. I've had some women that have had some bleeding and some infection from it, and then a lot of women that haven't. It just was like one more thing to do that was not the most comfortable thing to do. So I'm thinking probably that's why she switched it up here. The testosterone, just on a side note, so let's talk about testosterone a little bit. In women, when the testosterone therapy is too high, you'll have negative side effects. Right?
Almost invariably, yeah. That's one where you have to be a little careful, especially when you first start using it. That's why those pellets sometimes can be a little of a roll of the dice. You're not sure how that woman's going to respond. Is she going to have a favorable response and she's going to feel great, or is she going to have a bunch of anxiety and her face is going to break out because the testosterone's too high?
Yeah, that was my thought. Is what symptoms have you seen with somebody with a female having too much testosterone therapy? Well,
like I said, they go both directions. Some feel amazing for that first 3 to 6 months. Some don't feel very good. There's I don't know percentage wise, because you and I don't deal with the actual, implanting the pellets ourselves. So we sort of see the...
Oh, I meant regardless, any high testosterone, just so our listeners can understand if they're getting too much testosterone, what would be their symptoms?
Oh, sure. Yeah. Breakouts for sure. And anxiety are probably the two most common.
Yeah. I would say definitely, acne. I mean, you start some testosterone therapy, you're going to get maybe a pimple here or there, but not getting a lot. I've had women having acne all up and down their neck, where you don't get breakouts there.
Right.
Like you said, I would like to circle back around to the anxiety. I think people don't realize when you have high levels of testosterone, it can make you very anxious. Yeah, not necessarily testy. I wouldn't say I see that too much.
Yeah, I don't think women are getting roid rage from using their pellets.
No, but I would say the anxiety, hair loss, that's a big one. Sure. Just hair shedding, coming out. I mean, we all lose hair, especially if you've got long hair like me, and when you wash it, but like really a lot, maybe even a little bit of thinning on the top, thinning on the temples, because that would be considered androgen-derived hair loss. That's a common symptom. I wish I could say that the higher the testosterone, the higher the sex drive.
Yeah.
But it doesn't really work that way. Estrogen really is about the sex drive. I mean, adding in some testosterone can be beneficial for libido, but I wouldn't say the higher it is, the higher the sex drive. But I do...
In some ways, the higher the testosterone, at least for a woman, the higher the testosterone on lab tests, the lower the libido or sex drive. It almost has like the reverse effect. If they maintain those levels, especially with the pellets, if they maintain those levels too high for too long, you think they'd have a raging libido, and maybe they do for a little bit of time, weeks to months, and then it starts to fade after that, which is why you and I have never really been too big of fans of the pellets in general.
No. But, testosterone, I like to do the transdermal cream and find that balance, find the balance with the estrogen, find the balance with the progesterone. Yeah. That's really beneficial for libido and then other symptoms of perimenopause and menopause. But I would, like I said, I did want to circle back to that anxiety. So you too notice that when women's levels of testosterone are too high, they get anxious?
Yeah, they just feel, like there's almost like they're, now you get this sometimes with thyroid replacement, you get this with other things, but, they have this feeling like they're kind of buzzing inside, like they're internally agitated and they can't really quite put their finger on it, or they just have full-blown anxiety especially if they're a little bit prone to it. Now, or if they're not prone to it, all of a sudden now they've had, pellets put in or injection, all of a sudden they turn right back around and they have, some kind of issue. It's a pretty easy cause and effect that way, especially if they're not prone to the anxiety. Mm-hmm. And the anxiety piece, I think, is one that is not necessarily talked about ahead of time. Certainly the skin, the breakouts, all that kind of stuff, the physical things, but the emotional piece on the, like not so much anger and frustration, more so just feeling, anxious and kind of wound up a little bit.
That's interesting because back when I was working a lot with PCOS or women with polycystic ovarian syndrome, I would notice those women that had the higher testosterone, because that's one of the hallmarks of PCOS is the higher androgens, is they did have like this anxiety that you don't necessarily see. And that was like one of the biggest things we wanted to treat. Of course, we want to treat all the symptoms of PCOS, but the anxiety component, because trust me, I have a little anxious nature, don't I? That's just my personality.
Yeah.
It's not fun to feel anxiety.
No. Especially for those ones that have never had it before, then it's sort of like they don't want to go through that again and once you get the pellets put in, you can't do nothing about it. Those pellets are there, for months in order for those hormone levels to sort of drop off. So you're sort of backing yourself into a corner. Now, I've heard other women say the women that actually like pellets, they don't have anything to do once they're implanted. There's no upkeep. There's no daily maintenance. That's where I think, there's trade-offs, right? There's no free lunch. The less there is to do from a compliance perspective, now there's going to be a trade-off in some other capacity. And that is the tweaking of those levels over time, especially if a woman is just starting a particular hormone regimen. You start at a certain place. You and I have been doing this for a long time. You start one place, but you end up in a different destination. And it's always easier just to, kind of ease your way into that as opposed to doing something that's relatively permanent for a period of time.
So I know we kind of digressed from Cindy's question here, but I did want to talk a little bit about testosterone therapy. One thing she's kind of asking here is having her testosterone levels go up because she went from the Cypionate to the Depo and maybe she was absorbing it better. Her levels went up. Is that what is causing the vaginal dryness? And I wouldn't necessarily say too much testosterone can, in theory, there's these theories that, testosterone as a chemical structure or as a molecule looks very similar to estradiol. They're almost like mirror images. Mm-hmm. I think they're missing a hydroxy group or something like that. That testosterone can stimulate the estradiol receptors and create, some kind of reaction from that. I've always heard that as in theory, especially, 20 years ago, but I haven't really seen testosterone necessarily like block the estrogen receptor.
It does not get converted.
Act like
it
reception.
doesn't get converted.
Maybe in men, when men are taking testosterone, it can convert and aromatize and become estradiol. So that's one molecule converting over, but I wouldn't say that the testosterone somehow blocking her estradiol to create the vaginal dryness. I think that might have been maybe it just happened. I wouldn't say that. I think maybe her vaginal dryness actually is probably because her estrogen's too low.
Yeah, so that makes me think, that's why I asked you the question earlier, that makes me think the pellets had estradiol in it. Mm-hmm. And now the pellets have sort of worn off. She's gone to a transdermal cream, 50-50 Biest, at only 1 milligram. Now her testosterone was 334, has gone down to 219. The time of testing does matter there. Mm-hmm. If she's at 334 the day after injection, her number is going to be quite a bit different if it's 7 days later. But I think it's really nothing to do with the testosterone as far as the vaginal dryness. I think it's the switch from the pellets to a relatively very low dose of Biest.
Because I know that she said she was doing fine for the last 3 months, so she must have had the pellets a while back, started this new regime for the last 3 months, and then why is this happening after 3 months? You'd think, oh, well, the pellets were out 3 months. Why didn't this happen 3 months ago? But the body's really interesting that it might have even taken that time for those, for the body to respond, knowing that estrogen's lower. I guess what I'm trying to say is when I've had women have full hysterectomy, so they have their uterus and their ovaries out, they don't really get a lot of menopausal symptoms. That would be considered surgical menopause. Let's say they have them out, they don't have any hormones just yet. They don't get the surgical menopause or the menopausal symptoms till about 8 weeks after having that total hysterectomy or oophorectomy and hysterectomy. Why wouldn't they have that within the 8 weeks? It's something about the body having to say, oh, there's a change here. It takes a little while for things to happen. So I'm thinking you're right. She stopped the pellets. There was some estradiol in the pellets that somehow is now showing up 3 months later that her estrogen's too low. Because just as, like you said, we've been doing this forever, is a Biest of 50-50 milligrams, so 50-50 ratio of 1 milligram of Biest means that there is 0.5 milligrams of estradiol and 0.5 milligrams of estriol. That honestly is a pretty low dose for a full 24-hour period.
Yeah, this is the trend that we see all the time. We get all these questions, and the thing that is resounding over and over and over, women are trying to figure out where their dosing is, and it's always too little of a Biest dose, almost every time. Yeah. Now we're going to talk about probably another episode or the one after, about using the patch, which seems like even a lower dose than 1 milligram. We'll talk about that one on the next one. But that 1 milligram 50-50. So it would have been really nice to know. This is where the blood work actually plays a good role. Mm-hmm. What her estradiol level was on the pellet. Where I'm assuming, and based on what she's written here, I'm assuming that the pellet had estradiol in it. When those pellets first came out, what have they been around now? What, probably a decade?
No,
maybe
20 years. I remember back
years?
in 2004.
Okay, yeah, so they've been around a long time.
They've been around for
a while. But they used to only be testosterone only. They never used to have an estradiol component. That didn't come until later. That it was just testosterone in the early days of pellet implantation. And then I think probably in the last 10 years, it's been testosterone and estradiol.
Yeah. We went to a workshop for that, and that was back in like 2008. So maybe it has been around a little longer. Yeah. And that had the estradiol in it.
Okay, so 2008. So but I know before that, it was testosterone only. At least I think so. That is a long time ago, so I could be wrong. But
can you believe it's going to be 2025?
Yeah. So the fact that she was fine with the pellets is a good thing. That's why it would have been nice to know what her estradiol level was then. I guarantee you it's a lot lower now.
Well, that would be the thing right now is check her estradiol level. It's probably less than 32.
On 50 1 milligram, her estradiol level is going to be less than 30.
I'm surprised she's not having other symptoms like hot flashes, let alone just the vaginal dryness here. So I would say for Cindy and somebody that might be resonating, with her symptom picture, or maybe, what she's doing here is really she needs to increase up that estrogen, increase up the Biest, do it twice a day. I know that was a common practice a long time ago to just do Biest once a day. Biest really does not have a longevity for a full 24-hour period. You put it on, at 8 o'clock in the morning, it's going to be pretty much worn off by 8 to midnight later that evening, that you really want to do it twice a day. So I would encourage Cindy to raise up her dose and then do it twice a day.
Yeah, right. Now, she also mentions that she's used, she says estradiol cream. When you read the question, you said estriol.
I thought maybe it was a misspelling. It's estriol doll that she wrote, ESTRIDOL. So I'm thinking she's meant estriol.
Well, I thought the other way. I thought she meant estradiol. Either way, she says it doesn't work for her, but we don't know what the dosage is. We don't know how frequently she's been using it, because you can't use Biest transdermally and it really have a significant impact on the vaginal tissue.
I think it depends on the person. So some people, they do just fine with the Biest. They put on maybe on their inner thigh and their vaginal tissues, they don't have any dryness or atrophy. And then there's other ones where their levels of estradiol are pretty good in their bloodstream, but they're having, like you said, vaginal dryness.
Yeah. Then you have to, then you have your systemic dosage, but then you have one for a localized approach, and that's where she says estradiol. You thought estriol. It says estradiol. She says she's used
kind of a combination of both.
She's used Biest. She tried Biest a couple of times, which would be a combination, as you said earlier, of estriol and estradiol. We don't like to use estradiol vaginally. We like to just use straight estriol. But she's saying that hasn't worked before. What do you think is going on there? Do you think it's a frequency issue or a dosing issue?
Probably both. So the reason I don't like, and I know you don't either, like to put estradiol on the vaginal tissues is if you have a uterus, that can thicken the lining of the uterus and cause bleeding, where estriol, and there's some receptors in the uterus, I can't remember, beta, alpha, something like that the estradiol actually stimulates those receptors and causes thickening of the uterine lining, which can be a risk for a uterine cancer or cause periods or spotting, and can even, cause all sorts of, chronic spotting. So that's why I don't use the estradiol vaginally, and I know you don't either. But the estriol, which is weaker, doesn't have the effect or stimulate whatever alpha beta cells are or receptors in the uterine lining, so you don't get that thickening of the lining, so it's less of it doesn't have the risk factors that estradiol does, but because it's a little weaker, it, like you said, it's probably the frequency and the dosage just isn't enough.
Yeah, I sort of answered the question for you, but normally if it's returned, and for a woman in menopause, if you're not using something locally like that, and you are in menopause or in that transition, you can't use the cream something like temporarily and or use it for a while, stop it, because the issue will return because there's no hormones on the back end of that, so you can't. You sort of have to maintain those tissues for as long as possible. So we usually recommend every night for a week to 10 days, maybe 2 weeks. And then from there, women know their body better than anyone. They can start to reduce the frequency. And what would you say average, let's say we normally use 2 milligrams per gram of estriol. What do you say the average frequency is per month that a woman would use, or per week that a woman would use it?
I like to do closer, between 2 to 4 milligrams of estriol, E3, 2 times a week, maybe 3 times a week. And what I find, and I'm sure you find too, it's as late as it's like one more thing to do. A lot of women will tell me they haven't been using it. And I'll say, well, are your vaginal tissues dry? And they'll say, yes. And I say, that's because you haven't been using it. And so it's like trying to create that habit, trying to create that habit with women. I do a little stronger dose, and I know you do too, and a little more frequency if there's urinary incontinence. Sure, everybody, you cough, you do some jumping jacks, there's going to be a little leakage. That's pretty normal, or you can feel that. But for a lot of women, sometimes, just going for a walk, they have leakage. They go shopping if they and if they need to know where a bathroom is, like right away, because that urethra just gets a little lax. And estriol is actually really nice at tonifying that urethra just to kind of help with urinary incontinence. So it does kind of, I guess maybe I'm making it too detailed. It does kind of depend on the person and what we're working towards. But I'd say for vaginal dryness, vaginal atrophy, that, 2 times a week, 2 times a week.
Well, and it's interesting. So she says she tried the Biest cream, but how much did she use? Did she use so if you're using Biest, most?
Where does it say that?
She said she tried vaginally. She said estradiol in the past, it didn't work, and then she said she tried the Biest. So most women are going to be using a Topi-Click, right? That's pretty standard across the board.
Or the pump, like it looks like she's using that little pumper.
How do you know she's using a pump?
Since I increased one night to 1.5 pumps of my Biest cream, and she had a little vaginal discharge the next day, and that can happen too, because like I said, some women their uterine linings or their vaginal tissues. Everybody is different. But I would say, like you were saying about Cindy, that doing the estriol, doing a little higher dose, doing a little bit more frequency, and then increasing up her Biest.
Yeah.
Just systemically.
Sure. Yeah, you're right. I saw the pumps there. So, clicks versus pumps, that usually translates how many clicks you're using, how many pumps you're using, usually translates to a very specific amount, a very specific dosage. So knowing how much she's using, you can usually kind of, do the math and figure out. Now, you want to be a little bit careful with the frequency and how much you're using vaginally, but like you said, you kind of have to use enough given the situation.
Yeah, of the estriol. The estriol I feel safe with. I wouldn't want her to put estradiol in her vaginal tissues because she definitely probably has a uterus, because she didn't say anything about that. And then when she says I used 1.5 pumps of my Biest, she's on a 50-51 milligram, so that was probably 1.5 milligrams of the Biest, which would be 0.75 estradiol, 0.75 estriol. That's a little bit more, and she did notice a difference, so that probably would be helpful.
Yeah. It just probably needs, she seems like she sort of backed off a little bit, but she would probably need to maintain that for a little while. But that's where we don't use the estradiol. So if there is a little bit of frequency that's necessary, it doesn't, it's not going to make it's not going to solve one problem and then turn around and create another problem, because now you're bleeding on the back end of that.
What do you think? So testosterone injections, testosterone itself, especially for men, is like it's so thick. You have to use a really big needle, especially. It's like kind of scary if you're scared of needles. But why do you think she's using the testosterone Cypionate as an injection as opposed to not mixing it with her estrogen or doing it as a testosterone?
I wonder that. I've seen a few women over the years that are using testosterone, not a lot, but using testosterone injections. For the amount of testosterone that a woman actually can use without developing any of the side effects we talked about, hair growth, acne, all that stuff, I'm not really sure why they would be given testosterone injections, because you figure so you said, well, you did the math here, so so you figured hers is about 12 milligrams, which over a week doesn't sound like a lot. No. You wouldn't want to give a woman 12 milligrams a day. Yeah. Right? That'd be a lot. So what would you say for your patients? What is the average testosterone dose that you give them?
I mean, there are some that have pretty higher levels, close to 10 to 12 to even a little higher than that. But for the average, for most women, they do about 5.
Yeah.
5 a day. So, if she maybe even like 2.5 sometimes to 5 milligrams daily. Sometimes I'll split that up to twice a day. Testosterone's pretty good at kind of staying in the system that I usually just do it once a day if we're going to do it. Just depends on the person. I'm wondering if maybe, because there are some other practitioners out there, or some other thoughts I've noticed, people maybe on social media are talking about it. They're worried about the testosterone having an effect of getting on other people or other animals.
Sure.
But as a female, it's not a lot of testosterone, and then you can put it on the inner thigh or the back of your knee. That's not going to really transfer to anybody. And I'll tell you right now, as a female, if I took testosterone cream and put it on my inner thigh and it got on you, the amount of that testosterone is so small compared to what you make as a man.
Sure. Now, comparing that to children and pets, right? That could be a big deal. Even a couple of milligrams.
Estrogen, you wouldn't want to transdermal estrogen. You wouldn't want to get that on your kids or your pets.
That is one issue that has come up. But she's doing transdermal estrogen versus So I don't know. I think it must be practitioner preference. For some reason why they choose the injectable. I know injectable testosterone is relatively cost effective, right? That's another possibility, but nobody likes to inject that needle.
I mean, she could be, testosterone does help with athletic performance and building muscle if you're working out.
No doubt.
I wish if you put it on that you built muscle just putting it on, but you got to, do the exercise to build the muscle. So maybe, we don't know a lot about Cindy here. Maybe she's, an avid exerciser or working on fitness competitions.
Now this is her number. She said her numbers were pretty high at 334 when she went to the Depo-Testosterone. Now it's down to 219. She says my normal 219, which is not technically a normal number, right? That's still a relatively high number. But she must feel good at that number, or at least in the past she's felt good at that number. But that, what is a reference range for testosterone for a woman in menopause? It goes up
ridiculous.
to about 6. It goes like to 60.
No, it goes 2 to 45 at one lab, and then you're right. There's another lab, so it'll say like 7 to 65. That's a really big reference range. I always think, who made that up? Like, who made up 2 is normal, and so is 40? It's just so. Testosterone is one of those which I do feel is more individualized. So if maybe this number is good for Cindy, maybe she's an exerciser. I have a lot of women that tell me, while the testosterone may not be. We wish it was great for the libido, but really that's about the estrogen. But testosterone, I had a woman actually we were talking to, and it makes so much sense because I've heard this over and over, helps them get their to-do list done. Like it helps them get their stuff done.
Well, no, like you said, we don't know much about her lifestyle, as far as her, exercise on a weekly basis. But I do like to see a higher testosterone level. Maybe not 334. That's probably a little bit higher than it needs to be. But she said she didn't feel great at that level anyways. But from an athletic performance perspective, and all women that are in their 40s, 50s, and 60s and beyond need to be concerned about preserving muscle mass, potentially even building muscle mass, because it does not get any easier. It's hard enough for men to make muscle in their 40s and 50s, let alone a woman making muscle in their 40s and 50s. So having a higher testosterone level to kind of, push that, instead of the push always being towards weight loss, which I can understand, obviously, especially now with all the injectables on that side that are really popular, the GLP-1s, there's a problem there, is because now you're sacrificing your muscle tissue at the same time. And if you're in your 50s, you are not going to get that muscle back unless you're doing something very specifically to try to either preserve what you have or actually try to build it. And you cannot build muscle in a caloric deficit. It is just relatively next to impossible. So I do like to see numbers like that, as long as those cosmetic things are not really showing up, the hair loss, the hair growth, and the blemishes.
And like you said, the anxiety.
Yeah. And then on that, like I said, on that more emotional side. So it looks like her main symptom, though, which is interesting, her main symptom is the vaginal dryness. I don't think the testosterone plays too much of a role on that one, but like I said, we've talked about the estriol issue, which we'll probably talk about it a million more times, just because it comes up a lot. But these the tendency or the type of question that she's asking based on what she's doing, there's a theme to all of them. They all come in sort of the same way, which is interesting.
So I would love to see Cindy's blood work. Anybody that wants to write in questions, we love it. We've been getting so many questions lately. But if you did have any references to any blood work you've had done, I love all the number and the math stuff.
Sure. Yeah, that's why, like I said, in her case, it'd be nice to see what hers was before when she's on the pellets versus now. Because if her level is less than 30 and now she's back to having some vaginal dryness when she didn't have any for a while, based on what she's using now, of course, there's a significant drop off there.
Or even, checking, I would love to see her estradiol level, but even the FSH, the follicle stimulating hormone, I like to do that.
I'm sure her number is really high. I'm sure when she's on the pellets, it was really low, probably less than 10. And then now that she's off the pellets, or the pellets have sort of degraded, now her level is probably back up to close to 100 where it was before. Would be my guess, anyways. I mean, do you concur, Doctor?
I concur. I concur?
Okay.
All right.
I don't think there's anything else to say about this one. I think this one, we haven't done one of these in a while, so it's nice to kind of get back in the groove of actually recording video. There's a lot to put one of these together, even one. It takes a little bit of kind of behind the scenes preparation, but once we sit down and actually start doing it, it's actually pretty fun. So hopefully everyone is enjoying the podcast, the videos. We're now entering into putting some of our clips onto social media, which is a little bit scary. And
have an Instagram page. Can you believe it?
Yeah. So we're going to keep doing more of it. We're just learning as we go. So if you have any questions or comments, certainly this is going to be on YouTube. So down below, we monitor that as close as we can, and we'll just keep producing more content. So do you have anything else to add? Are we okay for now?
I think we're good.
Okay. Until next time, I'm Dr. Mackey.
And I'm Dr. Davidson.
Take care. Bye-bye.
Bye.